I am here today with a wonderful woman who is one of the best known physical therapists kind of in our community, Dr. Jessica Drummond. Jess, thanks for coming.
Thanks so much for having me.
So we've known each other for a few years. We both go to this meeting in San Diego that I think is moving this year to Tampa or something. But we're a group of in the wellness group called Mindshare, and Jessica is one of those people that is kind of revolutionizing a certain area of pelvic pain. Obviously, I send patients for pelvic pain quite frequently to physical therapists out here. A friend of yours is probably Amy Beth Hopkins.
Hmm hmm
She's in Austin, and I learned about pelvic floor therapy a few years ago, well, probably more than 10 years ago, actually, and it was kind of new at the time. Do you still see that gynecologists and other doctors don't send to pelvic floor stuff for pelvic pain? Like,
Well, I think it's definitely improving. So I started doing pelvic floor rehab around 2000, 2001. And there was a generation of physical therapists ahead of me: Holly Herman, Kathy Wallace, Fatima Hakim, Beth Shelley, who had created, and actually even before them, Elizabeth Noble had sort of created this subspecialty within physical therapy. So and then when I started doing this about 20 years ago, it was still very new. There were probably 50 to 100 total PTs in the US.
oh, wow.
And now it's definitely spreading. More gynecologists are certainly aware, but it's still an underutilized service. And in some parts of the world, it's less advanced. In other parts, it's more advanced. I would say Australia is probably leading the way, and
Oh, wow.
France has mandatory, well, not mandatory, but require, sort of their insurance gives every new mom something like 6 visits of pelvic PT. So it's definitely growing in understanding and utilization, but like everything else in medicine, it takes a while to really catch on.
Well, so you just wrote a book. I think it's an ebook right now called Outsmart Endometriosis. And endometriosis, as we are aware, it causes a lot of pelvic pain.
Mhm.
How did your work kind of bring you to specialize in the endometriosis aspect? I'm sure it came through pain, but how did you kind of get to the endometriosis part?
Yeah, so in my physical therapy, when I was doing full-time physical therapy practice in women's health, I did everything from incontinence to back pain in pregnancy, urinary prolapse. But the patients that I found would really struggle with kind of getting a complete solution, not sort of plateauing where they were better, but not fully better, would be my clients with pelvic pain. And endometriosis, as you know, is one of the key drivers of pelvic pain. We also see painful bladder conditions and vulvodynia and painful periods and painful sex and pelvic floor dysfunction. But endometriosis is very common. It's 1 in 10 women struggle with endometriosis. And it also, it's pervasive in that people have deep pelvic pain. They also have bladder pain, vulvar pain, gut issues. And so when my own practice transformed to include functional nutrition as a kind of other modality to interact with the physical therapy, I was able to bring a new perspective to endometriosis, which more and more the research is showing is inflammatory disease, has some autoimmune factors, especially related to the infertility piece of the puzzle. So, functional nutrition, as you well know, works really well to, at a root cause level, start dealing with some of those things. And then you combine it with the pelvic floor dysfunction that happens that physical therapy is really good at managing. You can really get a lot more complete relief of the full symptom picture that shows up with endometriosis.
So obviously, women that have endometriosis know what it is, but for those that don't, it's where the lining of the uterus or the endometrial cells get outside of the uterus and implant in the pelvis, ovaries, fallopian tubes, uterus, pelvic sidewall, colon. I mean, I've seen cases with tissue in the lungs,
Mm-hmm.
in old C-section scars. Actually saw one case where it was in her episiotomy scar from years ago.
Mm.
So it can be anywhere. It's almost cancerous growth in a way. It just doesn't kill people, but some of them probably wish they were dead because of the pain. And one of the things I was talking about earlier this week was that most women that have endo have about an average of 7 years delayed diagnosis. Just because, doctors are always like, oh, can we try this birth control pill or do this or do that? And we don't really come upon that. So what are the common symptoms that you would tell women in basically any age group to be on the lookout for that maybe, we obviously think of pain, but what other things can they be watching for?
Well, because that tissue, it's endometrial-like, but it's not exactly the same as the tissue inside the uterus. As you said, it can implant anywhere. It's like a benign cancer, non-cancerous cancer. And so what I see that often shows up first in when girls, we know there's a genetic component. So these lesions could have been there even from birth. That's the same incidence in female fetuses as it is almost. It's like 9% of female fetuses and 10% of adult women. So, or people with uteruses, we do see this in transgender men. So a lot of times these lesions are on the colon, as you said, or somewhere else in the digestive system. So they begin to be more problematic as we start the regular hormone cycles. So what will it look like when you start looking at the timeline in reverse is girls who are 8, 9, 10, 11, kind of pre-puberty, 12, showing up with digestive symptoms that are vague, but all their GI workup is normal, a lot of exhaustion, anxiety, and then there's period pain. Sometimes they're sort of like, the killer cramps, but it's often normalized because there's this genetic component. The family's like, oh, this is how women in our family have to deal with this, right? Like your aunt had terrible pelvic pain and your mom had a hysterectomy at 30 and so had infertility challenges. So, sorry, but this is what getting your period is like. Although it's actually true that for teenagers and tweens, the pain tends to be less cyclical, which kind of makes sense because, of course, the periods aren't regular yet. And so, going to the school nurse a lot with more like abdominal pain that they can't necessarily locate to the pelvis, because when you're 12, you're not really sure the difference between your pelvis and your abdomen. And like I said, there's a lot of fatigue, a lot of digestive issues. So that's what we see first in those sort of middle school years. And then obviously if there's a family history, that's a big red flag. And one of the endosurgeons I was talking to last week at the Endo Summit was saying, there's almost this like common picture of like having been on the bathroom floor in your middle school or your high school, and kind of putting your chin on the toilet and just trying to catch your breath, right? And that's definitely the kind of thing we hear over and over. So that's how, when you look at the timeline in reverse, you often see that it starts with that kind of thing in the middle schoolish years.
I was just having coffee with a friend and his girlfriend, and her sister just had surgery for endo, and she's having surgery next week. They both had that crazy bloat that you're talking about. That was kind of their main system, symptom, and they've been diagnosed for years with IBS. And the sister just had her surgery. She had stage 4. It was everywhere. And so she just was thinking for years that, oh, it's just what I'm eating. And partially I'm sure diet, that it would have helped a little bit. But when you've gotten to the point where you've eliminated the gluten, you've eliminated the dairy and all these other factors, and you're still having this bloaty, she would look pregnant for the most part, small person, but pregnant. So we mentioned, talking about some of the symptoms. And I know we don't know for sure, but what are some of the root causes? It's inflammatory, it's autoimmune, it's genetic. What else? Where else can we look at?
Those, I think, are the three sort of underlying factors. The problem is there's no good genetic testing yet. There's no way to find out if someone, for sure has endometriosis unless they have a good laparoscopy. So there aren't, we do see inflamed kind of inflammatory markers are called inflammatory cytokines in the peritoneum and, in the fluid around the female organs or around the bowel. And we also see changes in autoimmune, antibodies after someone has an excision surgery, but also obviously there's things we try to do with nutrition and all of that to help modify that autoimmune picture. But some of the autoimmune factors and inflammatory factors are actually being driven by the endolesions themselves. So the only true way to diagnose it, you can see some of this stuff on imaging, but not consistently. So it doesn't necessarily rule it out. So the only way to really rule out endo is a really good laparoscopic surgery by someone who does this. As you know, it's a difficult surgery. You've got to be looking in places that
Well,
you may not think of
now is
endo.
that it used to be years and years ago, we would do just cauterization. We would fulgurate or cauterize these lesions, and we've come to understand now that you can't really burn the tissue long enough to really get the entire implant. And so we've now started doing excisional surgeries where we excise the peritoneal edges around these lesions. And what I have found in doing that, technically it's a much more difficult surgery, but you will notice on bigger implants that the density of the fibrous inflammation underneath those is so deep that you really, burning them isn't really doing a whole lot. And so for years, even nowadays, women still do have doctors that'll go in and just do this, like they'll burn it and they're back, in 6 months. And even excision, while it's great, still you can't always see some of these microscopic implants that are still there. So we have with the Da Vinci now, with the robot, we have something called Firefly, which is where you can inject the patient with a dye while they're asleep, and it tags hemosiderin. And so you turn on a black light, just like, when I was a kid and we had the black light posters in our rooms, turn a black light on in the Da Vinci, and these little endometrial implants that you couldn't see will all of a sudden light up. So really cool in the advancement that we can now even excise stuff that maybe wasn't visible to the naked eye before. But let's say we don't want to go to surgery. Let's say we have somebody that's 13 or 14 or just a patient that really doesn't want to go to surgery. What can we do nutritionally to help with this problem?
Yeah, so I think stepping back to the endo belly, right, the bloated belly, we want to start with the digestive system because about 84% of women with endometriosis, their kind of most bothersome symptom at first is that constant bloating. So I think about endo with the bloating, we want to nutritionally optimize digestive function. So you want to start at the top, good chewing, really focused on absorption of protein. And most of the women that I've seen in my practice have low stomach acid for various reasons. Sometimes they were put on proton pump inhibitors for a long period of time. Other times they're just so fatigued and depleted by the time I see them that it's hard for them to just energetically make enough stomach acid. That's a very ATP or kind of chemical energy dependent process. So increasing stomach acid, giving consistent protein, which is going to help with some of the anxiety and some of the sleep challenges. And then digestive enzymes, motility support, which we can do with supplements, but we can also do with visceral physical therapy that can help with digestive motility, pelvic floor muscle relaxation, and bowel retraining kinds of programs. And then taking off the foods that are most commonly irritated, as you said, like dairy, gluten, but also help make getting the nutrient dense foods in, like animal proteins and vegetables and good fats, easier to digest. Because if you've been bloated for a long time, to just add 10 servings of vegetables, which is great for autoimmunity, is hard to digest if you're chronically bloated. So you're going to be doing cooked soups, things that are blended, things that are a lot easier to digest. And what we want to do is optimize the lining of the small intestine so we can quiet the immune response. So there are things like glutamine and zinc that help for that. And for a lot of my patients with endo, especially if they also have bladder pain syndromes, it's really common to have SIBO, an overgrowth of bacteria and or fungi in the small intestine. So we can use some antimicrobial herbs for that, again, helping with stomach acid, but also thinking about why they keep getting bacteria in the small intestine. And for endo, it's a couple things. One, low stomach acid, but also depending on where the lesions are in the bowel, it can be impacting the valves between the small and large intestine. So you end up kind of dealing, and sometimes depending on the extent of the surgery, if I'm seeing someone post-op, they don't even have an ileocecal valve anymore. So we're sort of battling chronic SIBO. And even if someone has a functioning ileocecal valve, the adhesions that the disease can create around the small intestine can create little pockets where it's easy to get either dysbiosis of the large intestine or SIBO, because there's these nice comfortable places for, unhealthier bacteria to grow. So between the small intestine and then optimizing good bacteria in the large intestine, again, with antimicrobial herbs or probiotics, really starting with digestion can make a big difference to the digestive symptoms, but also the mood symptoms, the exhaustion, and even pain, because a lot of times there's organ crosstalk. If someone's really constipated, they have pelvic floor muscle tightness, they might not even have any residual lesions around the like ovary, for example, but they could still have pain there from, fascial restrictions or chronic constipation, things like that. So from a nutrition standpoint, we really focus on starting with optimizing the digestive and immune systems and brain neurotransmitters, and then collaborating with pelvic PT to relax and get as much motility as we can in the pelvis and lower abdomen.
So Outsmart Endometriosis is the book behind you over your left shoulder.
Yes.
This is now available on Amazon, where you're kind of just bringing all this knowledge kind of into one place. And, looking around, there aren't really a lot of books on endometriosis that are out there. I mean, not only are there not books, sometimes there's a lot of books and a lot of them are worthless, but there aren't even books out there really. So
Right.
really great that you've kind of brought all this together, and you're kind of looking at, what is about, is there a plan, a formula in the book that women can kind of help themselves? Is it mostly a self-care thing? And what is the general, why would the book help women with endo?
Yeah. So obviously, as you talked about, I'm a big supporter of endometriosis excision surgery, because if, that in and of itself can help sort of get the lesions, at least to a large extent, out of the way for people who are good candidates for surgery. Not everyone is, and not everyone wants to have surgery. So whether or not you're going to have surgery, this book is everything. Either if you're not going to have surgery, you can still do it anyway. And if you are, it's sort of that pre-op, post-op plan. So it's really the same thing, both pre-op and post-op. But, we have athletes with shoulder surgery, coming from a PT background. You're thinking, well, why does a baseball player have all this preparation pre-op and post-op? Meanwhile, somebody who has been struggling with intense chronic pain and has a major abdominal pelvic surgery to remove extensive lesions in some cases, sometimes there's nothing really done before or after. So this goes through the nutrition, the movement, the sleep stuff, pelvic physical therapy, and gives many things that people can do on their own. And then if they need some support from nutritionists or physical therapists or pain management, physiatry experts, then there are resources in the book for that.
Well, that's a good point, because like I said earlier, it can take years for women to get a diagnosis. So in the meantime, they have 4 or 5 years of this chronic pelvic pain causing dyspareunia or pain with intercourse. Maybe their muscles in their pelvis have now changed or are tight on one side because they're protecting on the other side, or whatever. So now they've got years and years and years of muscle memory. So we can excise it. But if I just excise something, and not only I'm hurting her pelvis again because I'm excising something, but I'm poking holes in her belly, which is going to make her kind of, shunt her belly a little bit more for a few weeks. We're not really fixing maybe the underlying pain part. We're getting rid of the causative factor per se, but now we've still got this pelvic floor problem. So, yeah, you need to come at it from a multimodality insight, I think.
Absolutely, because even if you excise all of the extensive endometriosis, because the pain drivers could have been going on a long time, the digestive issues, the changes in, brain, pain neuroscience, the changes in the brain, the changes in the abdominal, hip, and pelvic floor muscles, that, there's all of that work to be done. And a lot of times that's what's actually causing the pain, not even necessarily the lesions, because there are women that have pretty minimal endometriosis lesions when doctors go in and actually do the excision. It's not always extensive stage 4, but the amount of kind of endometriosis in there is not correlated directly with symptoms. So you could still have really bad symptoms because of all these different pain drivers.
Exactly. And so I think, the thing that we see with endo more than anything is that this is not this disease more than any is not a one size fits all. I mean, pelvic pain as well, but I mean, pelvic pain can be so many things, but once you know it's endo, even if you know it's endo, there isn't necessarily one thing that is going to fix everybody. You have to have a team of people. And I would say physical therapy, gynecology, pain management, maybe some psychology if you also have sexual dysfunction over years and years. I mean, it affects relationships. It affects family life. These women, as a matter of fact, in your title is how to get your career back on track because it can affect your work. And so, I mean, this is something, do you talk about that aspect of it, that kind of psychological component?
Yeah, I do. And we have, so not only do we provide nutrition services, but we also provide health coaching services, which is essentially dealing with the biopsychosocial, like the behavior change aspects. But because Dr. Tu and his team presented a poster last year at the International Pelvic Pain Society meeting that showed that 74% of women with endometriosis say they didn't meet their life's potential. Like they essentially somewhere in their college, it's huge.
Yeah.
Because right around college or early 20s, you get just derailed from your career path because you can't show up, you can't, go to the tournament, you can't go to the SATs, you're dealing with pain at very inconsistent times and inconvenient times. So in the book, we talk a lot about how to build your web of support, how to navigate work and school, and who's on your team, both professionally and at home. Because what I've seen in my practice is women they learn how to power through. But that, you can do that for a couple of years, but at some point, your body just doesn't let you keep powering through. So you have to learn tools to navigate life with essentially an invisible illness while you're healing. And that's very difficult to do.
I think that's a good point. With a lot of things in general, women do that. After childbirth, they might have a significant injury or a episiotomy repair that didn't heal right, and they just power through, or fibroids and they hurt and they just power through, or they have to go. They get belittled because they have to go to the bathroom to change their pad every hour because they're bleeding heavy. I mean that is a very, and I'm a man, but I see this all the time. I hear about it all the time, and it's really, really infuriating that we do that because I think about men, I removed those little Esher coils, which cause a lot of pain. And yesterday I had a lady whose coil was literally, when I went in, it was literally protruding from the back of her uterus. It was sticking out. And she's had pain ever since the day they were put in. And I said to her, I said, if this coil was projecting from your husband's scrotum and he went into the doctor, it would be a national tragedy. Like he would be in the OR that day because all of our stuff is on the outside, and because we can't see it, that's why. And you mentioned invisible, you suffer with it, and it's really unfortunate. But yeah, I totally agree with you. It's really unfortunate that that women have to feel like they need to power through it. And I hope that with things like your book, that they can buy now on Amazon, that will be a little bit empowering. Why don't you tell me a little bit more about if people can work with you at a distance, or if they can come to you in person? How do they find you?
Yeah, so we have a virtual clinic. So I work with people all over the world. The website is the website is Integrative Women's Health Institute. integrativewomen'shealth.com. And you can find us also on Facebook and Instagram at Integrative Women's Health. And I do have a small physical space in Connecticut. So, I do some hands-on work, but usually I just collaborate with the physical therapist wherever the person lives. So we're very flexible with that. And the best way to find us is just to go to the website, send a little note to my team, or send me an Instagram DM, and we can point you in the right direction. I'm also happy to give all of your followers today a free copy of the book.
Yay.
Yeah. It'll be out in paperback. If you like the physical book, you'll have to wait till June. But if you want to just read the information, you can get it for free, the ebook version at outsmartendo.com.
That's great. Thanks so much. Again, Dr. Jessica Drummond, physical therapist, doctor of physical therapy, and author, actually of a few books. But this month we're focusing on endometriosis. I just want to say thanks for coming on. And thanks for everybody that's here that gets a free copy of your virtual book. And if you guys have questions, leave them in the Facebook log below. We'll try to answer them as we go. But Jessica, thanks for coming on.
Thanks so much for having me, Dr. Tassone. And if anyone tags me, I'm happy to jump in and answer questions later.
Awesome. Take care. Have a good weekend.
Thanks, you too.